Welcome to everybody. It's a great pleasure for me to discuss today personalized mechanical ventilation RDS before ECMO. I have no specific conflict of interest to declare for this lecture. And this is the result of a multidisciplinary and multi-professional collaboration that gave us the possibility to publish this recent paper in which we summarized some items related to personalized mechanical ventilation in acute respiratory distress syndrome. This was a multinational team and members from all continents in the world. Further, and I'm very proud of that, as a chair of the team, very well gender balanced. We had different expertise in different fields of problems related to mechanical ventilation in RDS, as well as each section was harmonized in a final version. And there are at the end of each section some summary suggestions. So we hope that this might represent a guide at the worldwide level to optimize personalized mechanical ventilation in RDS. The first point is the rationale. And we stated that it is important to regulate ventilator parameters based on close monitoring of target physiological variables, intervention responses, and individual integrated goals. In fact, we know that it's clearly understandable desire to standardize ventilator management in these patients. And the other side, randomized controlled trials and meta-analysis may provide summary estimates of treatment effects for clinical personalized approach to mechanical ventilation. However, definitive causal links between the applied pattern, VLI, or death and outcomes has not been clearly established yet. So it's very important to develop a sort of recommendation for personalized mechanical ventilation based on lung physiology and response to develop and inform for smarter ventilation practice. Tidal volume, and particularly lower tidal volume at 4 to 6 milliliters per kilogram predicted body weight, is actually considered as a standard of care. But also other personalized target measurements may be considered, and we will discuss soon, as well as the possible role of artificial intelligence and closed loop system that might provide even better monitoring. This is a typical example of lung with a certain amount of compliance, ventilated with a fixed tidal volume and associated with a relative driving pressure. If the amount of aeration is reduced and we apply the same amount of tidal volume, you can see here that the driving pressure markedly increases. So there is a clear influence of the amount of tidal volume delivered of the amount of aeration. So if we reduce the tidal volume according to the driving pressure, we can standardize and individualize the amount of tidal volume according to the amount of aeration attendance duration. So driving pressure is a very interesting parameter that might be considered to standardize and to optimize tidal volume according to the aeration of each patient. And we know from different studies, this is one of our meta-analysis years ago, that if we ventilate with higher as compared to lower tidal volume, when we ventilate with lower tidal volume, the amount of oxygenation is lower, the PCO2 is likely higher, and compliance is lower. But most importantly, when we look at the outcome, ventilation with lower tidal volume is associated with better survival as compared to higher tidal volume. So this means that oxygenation parameters and compliance parameters are not specific enough to obtain the better optimization of ventilation. So another possibility is that we can standardize mechanical ventilation according to the inspiratory capacity of the lung. So we move towards another area, so not considering the end expiration, but considering the end inspiration. You can see here that at different fixed pressure for different characterization of the patient, if we change the level of pressure, in this case from 0 to 30 centimeters of water, we can have major difference in terms of volume. So we can standardize, for example, the tidal volume, not according to the end S3 lung volume, which is more difficult to be measured and monitored continuously, but to the end inspiratory capacity, which may be performed with whatever ventilators is available. So our proposal is to start to consider end inspiratory capacity. So the difference from end expiration to end inspiration at the highest pressure of 30 centimeters of water as an indicator of the amount of volume that we can consider to standardize tidal volume. You can see also here that end expiratory volume is very well associated with the amount of inspiratory capacity. So we can look at the other side of the coin, in which an easier method to standardize tidal volume on inspiratory capacity. Of course, we have to consider that automatic system and artificial intelligence may help to have a better selection, control, and continuous monitor of tidal volume in these patients. We have to remind that the question of lower tidal volume is not only related to patients with RDS, but also different studies, including this, showed that, for example, the duration of mechanical ventilation was associated with the tidal volume delivered in non-RDS. Lower tidal volume was associated with reduced need of ventilation without any additional need of analgesia, sedation, and neuromuscular blockade agents. And also when we look at mortality and the RDS development, we found similar results. More recently, we published a large randomized controlled trial comparing lower and intermediate tidal volume in patients without RDS. And of course, intermediate tidal volume was associated with higher driving pressure, higher inspiratory pressure, but there were no difference in whatever endpoint we measured. So lower tidal volume has been to be suggested not only in RDS, but also non-RDS patients if tolerated with minimal sedation and assisted breathing. But if higher sedation is needed, a target tidal volume at 8 to 10 milliliters per kilogram predicted body weight, pending a plateau pressure below 25 centimeters of water, should be considered. And of course, if we ventilate in volume control, this is much easier to be obtained. You see here that it's much easier to have a differentiation between low and high tidal volume, which is more difficult when we are moving towards pressure support or assisted ventilation. So lower tidal volume is more difficult to be maintained in assisted ventilation, but again, if we need a higher amount of sedation, we can keep it up to 10 milliliters per kilogram, at least in patients without RDS. The third point is related to the driving pressure, which should be maintained below 13 centimeters of water as a target in the most patients with RDS. And driving pressure could help to individualize tidal volume in different peak levels. Pending that plateau pressure should be kept below 27 centimeters of water. And again, I show you in this cartoon that if we ventilate with the same tidal volume, the lower amount of aeration, we have an increase in driving pressure, which might be reduced with more aeration, but also again an increase if we have an application of and actually positive pressure to high. And we know there is a clear correlation between driving pressure and outcome of our patients. That's why we suggest to maintain these patients with a driving pressure below 13 centimeters of water. So lower is the tidal volume is also lower the driving pressure, and this is even more effective at higher elastance of the respiratory system. So lower is the amount of the aeration, lower is the compliance, and higher is the elastance. More attention we have to give to the amount of tidal volume and driving pressure. And we know also that we have a higher mortality when plateau pressure is above 27 to 30 centimeters of water. This is also important in non-RDS patients from our PREVENT study, showing a clear association between driving pressure and mortality. And also, again, plateau pressure is associated with increasing mortality in patients without RDS, but at risk of RDS. So we have to take care of the plateau pressure in patients with RDS, not above 27, in patients without RDS, not above 18 to 20 centimeters of water. The fourth point for personalized mechanical ventilation is related to the use of transpiratory pressure, which is estimated by esophageal pressure measurements that can be used to titrate ventilation, but it requires correct physiological interpretation and monitoring. This is a typical example where we measure esophageal pressure in the red spot, and this is located more or less at the 2/3 of the height from the sternum to the vertebra in supine position. And we have to consider that this pressure should represent the amount of pressure in the pleura at the same level. However, if we consider the pleural pressure in the non-dependent part of the lung, this should be corrected for 5 centimeters of water less, while in the most dependent part should be corrected for 5 centimeters of water more. Overall, we should consider as limit threshold of safety a transpiratory pressure attending inspiration in the non-dependent part of the lung below 15 to 20 centimeters of water, a driving transpiratory pressure of around maximum 10 to 15 centimeters of water, and recruitment higher pressure not above 25 centimeters of transpiratory pressure, while the pressure at hand expiration should be maintained at 0 to 5 centimeters of water above the level of PEEP. This is a typical example in which we have a transpiratory pressure negative, you see in the lower part of the panel, while here is a bit transpiratory pressure positive when we increase the pressure, the positive pressure at hand expiration. We have to consider the following items. The absolute difference not corrected, the airway pressure minus esophageal pressure, transpiratory pressure, attend expiration or inspiration is the transpiratory pressure estimated in the middle part of the lung. If the delta pleural pressure is equivalent to the delta esophageal pressure, but the measurement of the elastance of the lung and the chest wall might be accurate. However, attend expiration in the dependent part of the lung, the absolute transpiratory pressure is computed as PEEP minus PES minus 5 centimeters and should be corrected for this. On the other side, attend inspiration in the non-dependent lung regions, the absolute transpiratory pressure is computed as plateau pressure minus esophageal pressure plus 5 centimeters of water. Also, attend inspiration in the non-dependent part of the lung, the absolute transpiratory pressure may be also computed as plateau pressure of the respiratory system times the elastance of the lung divided the total elastance, in which the elastance of the lung is calculated as the driving transpiratory pressure divided the tidal volume, and the total elastance of the respiratory system is calculated as a total, the driving pressure of the total respiratory system divided the tidal volume. The first point to personalized mechanical ventilation is the mechanical power, which represents a summary variable, including the different recognized determinants of the LI. So it's the area of during the ventilation integrated of the volume and pressure. And different formulas have been proposed, and our opinion is that we should maintain the pressure included in the PEEP level to calculate the overall mechanical power. So mechanical power is the energy times the respiratory rate and may be calculated in volume control as a fixed constant 0.098 times tidal volume in liters times peak pressure minus driving pressure divided 2 times respiratory rate, while in pressure control, again might be calculated by 0.098 times tidal volume in liters times driving pressure plus PEEP plus times respiratory rate. So we know that we have different thresholds from anesthesia to more severe patients to determine those patients who can maintain that particular level of mechanical ventilation. And as you can see here, that in non-RDS patients, we should not exceed 17 joules per minute. And in RDS, especially severe RDS, we should think about ECMO, in my opinion, when mechanical power tolerance is above 27 joules per minute. So mechanical power is a very interesting target of ventilation and is associated with severity from non-RDS to RDS patients. We found that also in non-RDS patients, in a large population of patients, this was associated with increased risk of mortality when it was above 17 joules per minute, and this was associated with mortality due to the higher tidal volume and driving pressure, and the higher mechanical power was associated with mortality even at lower tidal volume and driving pressure. So it means that the summary of all these parameters plays a relevant role, and also the role of respiratory rate is very important in this setting and independent from RDS development and neuromuscular blockage as its use. So please consider in non-RDS patients an increased risk of RDS development when mechanical power is above 17 joules per minute. The other point is alveolar recruitment, which is related to the identification of recruitable patients and the estimation of recruitment, which are essential to individualized recruitment strategies. And this is a nice method that has been recently proposed by the Canadian team, which is related to the two pressure volume curves, starting from two levels of PEEP and the difference in volume that can be calculated. And this might allow the calculation, as you can see, in the difference in the recruitable volume at the highest level of pressure, in this case, 15 centimeters of water between the two curves. There are some patients that may also present some amount of airway closure, and this may be also considered in this sense. And in this case, as you can see here, the calculation has to be performed above the level of airway occlusion pressure. So the air-eye ratio may be calculated as the compliance of the recruitable tissue divided of the compliance of the PEEP low or above the airway occlusion pressure. And the compliance, of course, of the recruitable tissue is related to the volume recruitable, as I showed you before, divided the two difference in PEEP, while in presence of airway closure is calculated with the higher pressure minus the airway or the occlusion pressure. And you can see here there is a very nice correlation between the recruitable method or the experimental method in patients with and without airway occlusion. The gas exchange is also very important, which includes oxygenation as a commonly target to self-ventilation. However, also other parameters like dead space, ventilatory ratio, and oxygen transfer should be considered. We suggest to use usually the minimal lower PEEP FiO2 table as a target, a saturation between 88 to 95 with a PO2 range between 55 to 80 millimeters of mercury. Other parameters might be considered, like the ventilation ratio, which is the ratio between minute ventilation times PSO2 divided the expected minute ventilation, 100 milliliters per kilogram predictable weight per minute, times the ideal PCO2 in the normal subjects around 37, 38 millimeters of mercury, or above in case of previous COPD. And this parameter should be below 2 in most of patients. Other easier method to have an estimation of dead space and wasted ventilation mainly is to use or measure directly the dead space or the ratio between end tidal PCO2 and the real arterial PCO2, which should be maintained below 0.8. And also the PCO2 gap, the difference between capillary PCO2 and arterial PCO2 below 6 to 7 millimeters of mercury. So this is some other parameters that should be considered in the monitoring the evolution of the patients, and also to individualize the different parameters to minimize ventilator-induced lung injury. Of course, oxygen transport and capillary oxygen saturation from the central catheter should be considered. I remind 70% of the CVC or 65% from the lung gas, which is, however, less used in current practice. We know that if you use low piezo table is the best method to individualize PEEP in RDS. You see here that if we use this method, patients who are more recruitable are likely to have a higher level of PEEP, but not above 15 centimeters of water, and patients less recruitable with less level of PEEP. While other methods like driving pressure or stress index present a different association, so higher PEEP in less recruitable and lower PEEP in more recruitable, while esophageal pressure was not associated with any change. So I clearly recommend to use on the ventilators the PO2 table and to start the low PO2 table in most patients with RDS. As this was a slide that I took years ago in China during a visit and lecture tour in your country. Another point is related to hemodynamics. So we know that when we have a lower level of PEEP, we might have a certain amount of pulmonary arterial pressure, but when we have an increase in PEEP and we recruit the lung, we can observe a de-recruitment of capillaries, which might further increase pulmonary arterial pressure and impair the right ventricle. So when we use higher PEEP level, we squeeze out the pulmonary capillary from the alveolar side. And so this is very important that we may need a higher amount of lung vascular volume in order to recruit the capillaries and to reduce the pulmonary pressure. So higher PEEP levels are always associated with an increase in vascular overload. So that's why I think we should maintain PEEP at the minimal to moderate PEEP levels in order to avoid excessive increase in the afterload. So if you recruit the lungs, you de-recruit the capillaries, and at high PEEP level, you need fluids to yield capillary recruitment and improve right ventricular function. These are data from our most recent meta-analysis from a large number of patients. You see almost 2,000 patients per group, and you see that higher PEEP in intervention was associated with, of course, higher PEEP, 15 versus 10, with lower driving pressure and higher plateau pressure and better oxygenation. However, you see here that the 7-day, even driving pressure and plateau pressure are no more differences, just a little bit higher PO2 ratio. But if you look in terms of mortality, this was found only when the two interventions, lower tidal volume and higher PEEP, were combined. But in the other studies, there were no difference in terms of outcome. And even when we consider higher PEEP alone or higher PEEP associated with recruitment or just recruitment above, there were no difference in terms of mortality. And this, interestingly, was also very well confirmed from our data, even in more severe patients. And also, we did not find major difference in terms of outcome when we look at the titration of PEEP based on oxygenation or mechanics. I remind you that a recent study from our team with low versus high PEEP level in patients without RDS compared 0 to 5 to 8 centimeters of water. And you see here the difference in PEEP between the two groups, almost 2 or almost 8 in the higher PEEP group was not associated with any difference in the main outcome data. So even in the patient without RDS, we suggest to start with relatively low level of PEEP. So this led to our concept of close the lung and keep the resting to minimize ventilator-induced lung injury, with the concept of primum non nocere. Just gently ventilated the aerated lung, keeping the atelectasis at rest, and use a minimal PEEP for a minimal saturation and PO2 within this range in order to minimize possible right ventricular impairment. So we have to use low tidal volume, which is associated with low driving pressure and plateau pressure, minimizing PEEP and oxygenation. Sometimes we need a little bit increase in hemoglobin in order to optimize oxygen transport, but avoid routine recruitment maneuver and PEEP above 15 centimeters of water. Of course, these strategies has always to be connected with proposition. Lung imaging is very important, and computed tomography remains the gold standard in this setting, but also lung ultrasound and electric impedance tomography are very promising bedside tools. You know, this is a typical CT scan in recruited and recruiters, and I remind to all of you the CT scan should be performed at least at 2 levels of pressure in order to have important information in the pathophysiological reasons, entities of the wide densities in RDS, but also focal and non-focal alteration may be detected by lung ultrasound, and also the AT might be helpful. So different strategies might be helpful, and again, I would like to emphasize strategies that may be used at the bedside. Phenotype stratification has been further under discussion. It is very promising, but translation into clinical practice requires further research. This is one of the first studies showing different phenotypes, phenotype 1 and phenotype 2, and according to the different variables in terms also of outcome. And the more recently, you see here that hyperinflammatory as compared to hypoinflammatory subphenotypes responded differently to simvastatin, so this might be open also to different response to treatment. And of course, different factors has to be considered in the different phenotype stratification, from physiologically derived, clinically derived, biologically derived, and omics derived, and the possible utility in the next future. The final point is that we have some limits to the physiological targeting of optimization of mechanical ventilation, because when we apply physiological manipulation, clinicians should also consider the uncertainty surrounding their effects on patient-centered outcome. And this is called the med physiology. In fact, physiological measures whether a specific intervention affects a specific set of physiological parameters. However, physiology not always assess other unmeasured or unintended physiological consequences. So better physiology sometimes does not necessarily translate into improved clinical outcomes. So we have always to balance the optimization of most of physiological parameters and real clinical outcomes. So this is to conclude my lecture on how to optimize mechanical ventilation in RDS before ECMO. If patient present PO2 above 200, we can start using non-invasive respiratory support. But when we have higher tidal volume or PO2 below 180, within 1 to 3 hours, we have to move towards more aggressive treatment. In case of PO2 below 100 and 200 or below 100, we should start with invasive mechanical ventilation with low tidal volume, with a minimal respiratory rate according to the pH, with low plateau pressure below 25 to 27, low driving pressure below 13 to 15, minimal oxygen saturation target between 88 to 92, and use recruitment user eventually stepwise only as a rescue. In case we need the mechanical ventilation, we should move first towards a BiPAP, so assisted ventilation with 10 to 20% of spontaneous breathing, with minimal PEEP setting and maintaining mechanical power below 17 joules per minute. If the patient is more severe, of course, we have to use a little bit higher level of PEEP, but we need 10 to 15 centimeter water, maintaining mechanical power as much as possible below 27 joules per minute, and use immediately prone for at least 12 to 16 hours a day. If you have PO2 between 100 to 200, again, we should start with assisted ventilation in BiPAP with a little bit higher range of PEEP as compared to the other group, and maintain mechanical power below 22. But if the PO2 FO2 remains below 150 at 24 hours, or we have an increase in inspiratory drive with a PO1 above 3 centimeters of water, we should immediately move towards a prone position. Neuromuscular blockade agents should be used only if needed, and echo-TUR or ECMO should be considered when the patients maintain a PO2 ratio below 80 and pH below 7.25 or lower, with a PCO2 above 60 mmHg for at least 6 hours, and a plateau pressure above 30 centimeters of water. Most importantly, we found that when mechanical power is above 27 joules per minute, we should start to think about ECMO. But the message here is that before starting ECMO, in my opinion, due to the possible negative consequences of this technique, we should try to optimize and personalize according to the 10 rules that I discussed mechanical ventilation in these patients. So change your mind, keep the lung closed and then rested to minimize VLIs in RDS. Less is more. Open the eyes, not the lung, at any price. Thank you very much.